Okay, we're set to go.
Hi. Good morning. Uh, Glad to introduce Dr. J.D. Odom, who is a geneticist who joined Christus Children's Genetic Division July 2022. His practice focuses on general genetics and inherited metabolic disorders affecting a child's overall health and development. Dr. Odom completed a fellowship in medical biochemical genetics and a residency in medical genetics and genomics at Baylor College of Medicine in Houston. He earned his medical degree from the University of Florida Morsani College of Medicine in Tampa and completed pediatric residency at the University of Maryland Medical Center in Baltimore. Topic for today's talk is of utmost relevance to our growing pediatric liver transplant program, as we have recently evaluated 6 or 7 patients, actually mostly from his practice, with various metabolic conditions. All of these are rare conditions, but each with unique challenges. For example, liver transplant may cure some, but not all. Our strength living related liver transplant program may not be an option for many of these conditions. And then perioperative management. Perioperative management has to factor in unforeseen situations if graft non-function or rejection, etc. So you can see there's a lot to learn, and I'm glad to have Dr. Odom agree to educate us today. Thank you, Dr. Odom. It's yours.
Okay. Yes, thank you, Dr. Mittal. So my name is J.D. Odom. I am the director of the metabolic program over here at Christus Children's Hospital, and I'd like to give a thank you to Dr. Mittal both for giving me the opportunity to speak here today, but also for setting up this sort of therapeutic relationship in the first place. When I first moved to San Antonio, he was very proactive in setting up meetings and introductions, and so yeah, as he said, a number of my patients have been referred to him, and it's really useful to have this liver transplant program here in the city for patients that are local. So today we'll be talking about the role of liver transplantation in patients with inborn errors of metabolism. And so to start with, no disclosures. In terms of objectives for today's talk, first we'll be covering what is an inborn error of metabolism. We'll look at some of the ways that we treat these patients
for inborn errors of metabolism.
And then we'll look and see how liver transplant can be used for some of these patients. So first things first, before we talk about inborn errors of metabolism, let's just talk about metabolism in general. And this can be thought of as all of the chemical reactions that make up an organism that are used to keep it alive. And this can be the conversion of food into energy or other cellular structural components. This could be the synthesis of chemicals that are vital to the cell to live. And this is, of course, the elimination of waste products. And so here's a little diagram of food. You have your metabolism, and you have just the state of being alive. And by the way, I know that I'm a metabolic geneticist. This is about as complicated as the diagram will get in this presentation. I'm not going to show any pictures of the Krebs cycle that make you look at that stuff. Certainly not at 7:30 on a Friday. So that's metabolism. Then what's an inborn error of metabolism? Technically speaking, if you want to get technical, the definition is any disease where the impairment of an enzyme or biochemical pathway is intrinsic to the pathomechanism of the disease, which, if you try hard enough, probably this definition extends to every disease. But in general, I like to think of it, you'll have some type of mutation in your DNA that leads to a defect in an enzyme, and then you are unable to metabolize whatever that enzyme was supposed to be doing, and that leads to an accumulation of toxic substrates, upstream of the defect, and then you lose those products that are downstream of the defect. And so when we talk about inborn errors of metabolism, the thing that we worry about the most is the dreaded sort of metabolic decompensation. And this is an acute, severe decline in these patients, usually preceded by some type of catabolic trigger. And the metabolic decompensations have a high mortality and morbidity. Usually they're going to look like acidosis or high ammonia, hypoglycemia, some type of encephalopathy or stroke. When we talk about catabolic triggers, we talk about anabolism versus catabolism. You can kind of think of anabolism as think about anabolic steroids, right? Bodybuilders take these to build up their muscles, grow bigger, right? So anabolism is the act of growing and becoming bigger, versus catabolism is the other side of that, which is the breaking down of products and that sort of stuff. And so for patients, when they're healthy, when they're doing well, it's not so hard to manage these patients. They're taking their medicine, so their drugs are at a steady state. And then, me and my dietitian, we are in control of how much of those toxic precursors they're taking in, right? We're doing the math, we're tailoring their diet, sometimes down to the milligram, right? We know, okay, how much leucine is this patient actually eating? But whenever they're sick, whenever they have a metabolic decompensation, all of that goes out the window. They're throwing up, so their drug levels are all over the place. And when they are catabolic, the body is breaking down internal stores of fats or protein, and you're having unregulated amounts of these toxic precursors, being exposed to the body, and so that can be a real problem. And these catabolic triggers, usually it's illness, but we also have to be careful with surgery or anything that is particularly stressful to the body. In terms of management for inborn errors of metabolism, there's a couple of sort of first principles that we follow. And we'll use an example of, we'll talk about patients with OTC deficiency in a little bit, but this is a urea cycle disorder. But step one is to minimize the accumulation of those toxic substrates, right? Which is in the acute setting, looks like making patients NPO and starting them on high glucose infusion rate fluids. Chronically, again, using the example of an infant, what that might look like is you need a certain amount of protein to survive, right? So we'll kind of put them on the RDI for protein intake for their age. And, it varies with condition, but for OTC deficiency, that might be 1.5 grams per kilo per day of protein, about half of that coming from sort of just essential amino acids, and then half of that coming from regular protein, sort of in an attempt to minimize their nitrogen exposure. You have to supplement the products that their body can no longer make, right? In the acute setting, you'll give someone IV arginine. This, again, the example is OTC. But chronically, these patients will take citrulline, right? For you or me, we don't have to eat citrulline if we don't want to. Our bodies can make it. But for these patients, they can't. And then third principle, removal of harmful metabolites, right? In the acute setting, you might use dialysis. That works for essentially any inborn error of metabolism. For urea cycle disorders, you might use aminol. And then in the chronic setting, you'll use other medicines to help remove those toxic substrates. The nitrogen scavengers we classically use for urea cycle disorders are these medications. So that's how we usually treat these patients. What else can we do? Well, you can transplant them. Obviously, today we will be talking about liver transplantation. You can also use bone marrow transplant for select disorders, which we won't get into, but certain lysosomal storage disorders, certain leukodystrophies respond quite well to bone marrow transplant. And for many conditions, even though, you're just transplanting the liver, right? That liver can actually clear all of the toxic metabolites and effectively offer a cure for these patients. In this diagram here, we have sort of a representation of a liver transplant in a patient who has maple syrup urine disease, MSUD, which we'll talk about. So you have your, healthy donor, and they have essentially 100% enzymatic activity of the MSUD enzyme, the BCKHD enzyme. And you take their liver and you put it into this patient, right? And MSUD is expressed pretty ubiquitously throughout the body, but that liver, we say for argument purposes, you'll get their total body enzyme activity up to about 15%. That's enough for these patients. And in MSUD, the liver transplant really could be described as curative. This diagram is actually describing something that is relatively unique to MSUD, which is a domino liver transplant, where you then take the patient's liver, which still has MSUD, but then you transplant that into someone else who does not have MSUD, and the rest of their body is able to compensate for this. So you can see this patient, has, for argument purposes, maybe 85% residual enzyme activity. I will say that is the exception, but not the rule. For most of the disorders that we'll talk about today, transplanting a diseased liver into someone else, that person just now has that disease. Yeah, and then we won't get into it today, but this question comes up all the time for patients who, for parents who want to be live donor for their live donors for their kids. The parents are usually going to be obligate carriers for these diseases, and so should we do that? Is that a good idea? And the answer is it's complicated and it's disease specific. Yeah. So in terms of liver transplant for inborn errors of metabolism, even partially responsive disorders, right? Even disorders where we wouldn't say, oh, this is curative, there's still some pretty substantial benefits for patients. One is, and this is probably the biggest one in my opinion, oftentimes this can provide a substantial reduction in the risk for metabolic decompensation. And that's a big deal for families, because you might have a patient who is quite metabolically stable and doing well even for months to years, but there's no guarantee that they won't get the flu or catch COVID or whatever. And then all of a sudden, now we have some pretty severe neurocognitive defects, deficits. The other thing, for certain metabolic diseases, transplanting the liver can stop any worsening of neurocognitive defects. It doesn't necessarily, you don't get anything back, but you won't continue to decline following liver transplant. And then, these two are probably the biggest for myself and maybe for the parents. For the kids, loosening of dietary restrictions is probably the biggest one. And because it's simple for me to say, okay, go out and only eat 0.95 grams per kilo per day of protein, but that is tough, especially if you're a teenager. You want to go to the mall, you want to eat pizza with your friends. A lot of protein in cheese, a lot of protein in pepperoni, right? So you just can't. Now, in the past, transplant has really been reserved for very severe patients or patients where we didn't have any other options. But in recent times, there have been improvements in the technology and the medicines and probably in the surgical techniques. And so survival and patients and graft survival are just getting better over time. And so the improvements in transplant technology have shifted that risk-benefit ratio in favor of transplant for many patients, even for patients who are more mild or diseases where previously you might not have necessarily considered that. And so in these cases, I tend to think of transplant not necessarily as life-saving, but rather life-altering for these patients. And in terms of the numbers, so this was a study looking at the split registry from 1995 to 2008. And they had just shy of 500 patients who had undergone transplant for some type of metabolic indication. And that made up just shy of 15% of their cases. Another study was looking at transplant recipients from 87 to 17 to 2017, and they had about 6,000 patients who underwent transplant for metabolic disease. Of those, about 40% were pediatric patients. This study had broken up the study into three different eras, three different decades. And the last decade, from 07 to 17, the 5-year survival rate for pediatric patients who had metabolic disease, their survival rate was 94.5%. And 25-year survival rate for metabolic patients was greater than 70%. In terms of what sort of predicted better or worse outcomes, the younger you were, the better you did. And if you had structural liver disease, the worse you did. And just to steal a quote from the authors of this paper, which I thought was pretty powerful, they said the long-term survival report for children demonstrates a realistic expectation of close to normal life potential, right? Not life expectancy, but potential, right? So that's the potential to go to college or the potential to start a family in the future. And so transplant is looking more and more like an attractive option for these patients. And so this next slide is what we talked about, but in graphical form. Again, the red line would be patients who had both structural liver disease and extrahepatic manifestations of their metabolic disease. And so they did the worst. Keep in mind the time frame is 10,000 days, which is around 27 years. But for other patients, they actually did rather well in terms of survival. So let's talk about some disorders. These are metabolic conditions, quote unquote, metabolic conditions that are amenable to transplant. I've put metabolic in quotes just because, again, some of these diseases, maybe you do, maybe you don't consider them metabolic. And then I put amenable necessarily because many of these diseases have better or different treatments as opposed to transplant. For the ones that I've highlighted today, that's what we'll talk about today. This is the same study that we were looking at before, the one that had broken up the patients into the 3 different decades. And I just want to highlight the percentages here of patients who were undergoing transplant. So we'll talk about all these in detail, but tyrosinemia type 1, I think, is a good example, right? In the first decade, in 87 to 96, about 10% of the patients that were transplanted were tyrosinemia patients, right? But then if we go over here to more recently, only about 1.8% of patients are transplanted. And that's because we have a very good medicine called intisonone now. Most patients with tyrosinemia type 1 no longer need transplant. And of course, it's on the newborn screen. So we're catching patients early, getting them started on treatment pre-symptomatically, and they're doing very well. On the opposite end of the spectrum, we have urea cycle disorders, right? In the past, maybe 6% of patients were getting transplant patients getting transplanted represented urea cycle disorders. Now it's 21%. And so this is an example where liver transplant is pretty much the go-to option for patients with urea cycle disorders. There's some caveats there, but we'll get into that. And then GSD type 1 has not really changed over the years that much. I'll point out that for MSUD and for the organic acidemias, nobody was getting transplanted in the past. Now, actually, a decent number of patients are. And so, this is one where over time, transplant has really started to look more and more like an attractive option for these patients. So let's talk about some specific metabolic diseases in no particular order. We will start with maple syrup urine disease, or MSUD. So this is a autosomal recessive disease. Mutations in any of these genes can cause this. And what this is a problem breaking down branched chain amino acids. So branched chain amino acids, right? If you were to go to GNC and buy BCAA powder, you're buying valine, leucine, and isoleucine. And what this looks like in the acute setting, so an infant coming in at day 5, day 6 of life, they'll be encephalopathic. And for them, that looks like hypertonic episodes, epistatonus. They'll have these characteristic boxing or pedaling movements. These are non-epileptic at first. If you don't treat this, eventually they can develop seizures, but this is just a particular movement disorder that this type of encephalopathy further reduces. And then classically, as the name suggests, right, maple syrup urine disease, they have a sweet caramel smell in their urine and in their earwax. Just as an aside, I do get calls every now and again about patients who are older, who are relatively healthy, who have sweet smelling urine, right? And they say, oh, do you think they have maple syrup urine disease? The answer is probably not. By far the most common cause in that situation is just, we never figured out. We don't know why their urine smelled sweet. But you also want to think about DKA. Any kind of ketone is going to have a sweet smell to it. And the other thing is fenugreek, which is it's used a lot in Asian cuisine. It is also a breastfeeding supplement. So sometimes moms will be on a fenugreek tea or something like that. And the sodalone from that will get passed through mom to the baby, to their urine, and everything will smell sweet. And so that can often do it as well. So this will be an example of those boxing or pedaling movements that you can see. Again, in this baby, I think this says this is HIE with seizures. So in this baby, they are epileptic, but in MSUD, they will not be. So you can see the arm movements, you can see the leg movements. So how do we diagnose MSUD? If you talk to a metabolic geneticist, there's sort of three classic tests that we order. One is plasma amino acids, urine organic acids, and a nasal carnitine profile. In this case, the plasma amino acids is the one that makes this diagnosis. MSUD is on the newborn screen as well, and that's what we're doing. We're looking at the amino acids in their plasma. And so what you see is you see elevated branched-chain amino acids. By the way, you see all three elevated: leucine, isoleucine, and valine. It is the leucine that is actually the problem and the one that leads to the encephalopathy. Also, you'll see the presence of alloisoleucine, which is an isomer of isoleucine. And this is found at very low levels, if at all, in regular human plasma, but it's just present in these patients. And so if you get your plasma amino acids back and you see alloisoleucine, there's your answer. Your patient has MSUD. And so in terms of traditional management for these patients in the acute setting, right? You have a baby come in, they're encephalopathic, their leucine is 4,000. That patient just very clearly needs dialysis. Get that leucine down as low as possible, as quickly as possible. The other thing you can do, though, let's say everything from a newborn screening perspective works, right? You catch the baby early, they're pre-symptomatic, they're doing relatively fine, they're protecting their airway, they can eat. You actually don't have to do dialysis. What you can do is you can put them on a very high protein, very high calorie diet, one that does not have isoleucine, valine, or leucine in it. You will end up supplementing isoleucine, valine. And what happens is you let the baby grow, right? And they will take the leucine in their blood and they will start to incorporate it into their own proteins, their own muscle mass. And very quickly they'll burn through the leucine in their blood. So it's a very nice way of avoiding dialysis for these patients who are doing relatively well in the acute setting. And then chronically, this just looks like limiting leucine intake. Again, me and my dietitian will sit down, we'll provide family with recipes and diets and to aim for quite literally a certain number of milligrams of leucine per day to make sure that they do well. In terms of outcomes for MSUD, how do we do? We do okay. So this first one is looking at IQ for patients with MSUD. Again, if you're in that period where the newborn screening works, we catch you early and we get you treated, and you have no encephalopathy when you're born, your IQ is probably going to be normal. The shaded region is anything normal here, right? Your IQ will be less than your siblings, right? There is something about leucine, higher leucine values that leads to lower IQs. And that's what this graph over here is showing, that the higher your lifetime leucine exposure is, the lower, kind of see, the lower your full-scale IQ will be. And then going back over here, let's say you are encephalopathic in the neonatal period. Oftentimes those patients are getting down into and qualifying for intellectual disability. So what is our role of liver transplant for maple syrup urine disease? Well, essentially what it lets you do is it lets you take them off their diet, and it lets you their leucine values be close to normal, if not totally normal. So this was a study looking at 77 patients that they had transplanted over, some of them over greater than 10 years. And they had 100% patient survival. They had 99% graft survival. All of their patients were able to come off their diet, and none of their patients had any more metabolic decompensations. And you can look over here again, isoleucine and valine are not as important as leucine. But you can see the years post-liver transplant, 1 to 3, 4 to 7, and 8 to 10. And this dotted line here would represent sort of the upper limit of normal for leucine. And so keep in mind, these are on unrestricted diets, right? So, if you take a patient with MSUD and you put them on an unrestricted diet, you're going to be in the hospital in a few days with leucine values, 5,000 or greater. But these patients actually did okay. And they're hanging out high normal, slightly above this. So it's a pretty good option for these patients, and they tend to do really well. This is a disease where I might even use the word curative when talking to families about transplant. So that's MSUD. Let's talk about the urea cycle. This is responsible for removing waste nitrogen from the body. So the way things usually work is you eat food, you eat protein, and that is just chains of amino acids, which will, there's not a good way to store amino acids for later in the body. And so what you're not using right away, you have to get rid of, right? And so that looks like you convert that into ammonia, the waste nitrogen, and then you convert that through the urea cycle into urea, and you pee that out in your urine. That's the name. But if that just doesn't work, then you'll have very high levels of ammonia and all of the fun that comes with hyperammonemia, right? Coma, death, etc. And so urea cycle, primarily responsible for the detoxification of ammonia. It is made up of these 6 enzymes, some of which are on the newborn screen, most of which are autosomal recessive. I'll only point out ornithine transcarbamylase deficiency, OTC, because 1, it is the most common, 2, it is quite severe, and 3, it is not on the newborn screen. It's the most common because it's X-linked. And we just haven't found a good way to screen for this at a population level. So these are the patients who will come in, in the neonatal setting. Hour 6 of life, hour 36 of life, very high ammonias and very severe disease. These patients go straight to liver transplant. The hyperammonemia itself, this leads to astrocyte swelling and cerebral edema. Initially, the high ammonia will actually stimulate the respiratory centers of the brain, and you'll get hyperventilation, you'll get a respiratory alkalosis. Obviously, if you let the cerebral edema go for too long, then you will herniate, and then you stop breathing, and you'll have the opposite problem. But initially, they'll have a hyperventilation. So how do we, traditionally speaking, take care of patients with urea cycle disorders? Again, going back to those first principles of management, you want to stop and or remove the buildup of substrates proximal to the defect. In this case, that's ammonia. And so there's sort of 2 sources of ammonia. You have exogenous, right? That's just protein that you're eating. Okay, that's easy. We make the patient NPO. But then you have endogenous, right? So when these patients are in a decompensation, when they're catabolic and they're breaking down internal protein, you're having quite a lot of nitrogen load for these patients. And so what you'll do is you'll give them a high glucose infusion rate. Usually I aim for 6 to 8 mg per kg per minute. The idea behind that is providing a high enough glucose infusion rate to stimulate insulin release. And then insulin is a signal, should hopefully flip them from that catabolic state back into anabolism and stop the breakdown of endogenous protein. And so I highlighted this is probably the most important thing. D10 NS at 1.5 maintenance. If you remember nothing else from this talk, if you're in the ER, if you're a hospitalist, this will in the short term treat most metabolic patients and give you plenty of time to call me or get them to a metabolic center. And then in terms of our options for removing ammonia that's already there, we have nitrogen scavenger medications, and dialysis works quite well as well. Going back to principles of management for these patients, you want to supplement products that they can't make. In this case, that might be IV arginine in the acute setting. This essentially gives them a slightly different path to remove some nitrogen from the body because they can make arginosuccinic acid, and then they can get rid of that in the urine. So how do we do for patients with urea cycle disorders? Okay, in terms of cognitive outcomes, this graph is looking at IQ versus duration of coma. So your duration of your coma in the neonatal setting. And what you can see is if we are catching you early, figuring things out, and getting that ammonia down in the first couple of days, then your chances of having a normal IQ above this red line here are pretty good, right? Versus if the duration of the coma is lasting longer, out 6, 7, hopefully it doesn't take you that long to fix this these days, then you're going to have some pretty severe neurocognitive deficits from that. And this study was looking at, they had broken up patients with urea cycle disorders into pre-2000 and post-2000 and looking at the percent that had intellectual disability. A few notable examples here, we don't have to go through everyone, but NAG-S deficiency, right? In the past, it was about 50-50 whether or not you had intellectual disability or not. And now very few do, thanks to a medicine called Carbaglu, which works very well for them, but pretty much only for them. OTC males, again, not much has changed there just because this is a very severe disease for those patients. Citrullinemia, we're doing quite well now. ASL deficiency, we went backwards a little bit. If we were to redo this study now, this number should be a lot better. Historically, treat these patients with just a ton of arginine. And as it turns out, for complicated chemical reasons, that's not great for your brain. So now we have patients on low dose arginine, and we see hopefully better neurocognitive outcomes now. So transplant for urea cycle disorders. These patients are great candidates for transplant. Despite advances in the medical management for these patients, they're still at risk for life-threatening hyperammonemic crises, and that can have some very severe mortality and morbidity associated with that. And the general consensus among the field is that having a liver transplant is less dangerous than just trying to manage these patients and live with this condition. And so transplant eliminates the risk for hyperammonemia, right? You really just don't, it's curative from that perspective. And it halts neurocognitive defects, except for ASL deficiency, for reasons that we won't get into. But if you transplant someone with ASL, they're not going to have hyperammonemia anymore, but they will still, unfortunately, have neurocognitive deficits. And then the other thing, so the urea cycle in the liver is responsible for detoxifying ammonia and making urea. In the intestines, it is responsible for making arginine and citrulline. For you or me, those are non-essential amino acids, but for these patients, they're pseudo-essential, and they do have to supplement them. And so you'll supplement these even after transplant, right? Because again, their gut still has OTC deficiency, but you do the transplant for the hyperammonemia. It's no big deal to take supplemental citrulline. So how does liver transplant help for these patients? Helps pretty well. So this was a study looking about a 20-year period. They had at their institution done just shy of 500 liver transplants in that time. About 16 were for urea cycle disorders. And I'll point out again that you can see that in the first decade, right, only one person underwent transplant versus in the second decade, 15 did. And so patients did quite well. 5 were neurotypical, 9 had mild delay, and 2 had severe delay. These were both male OTC patients, again, very severe disease. But notably, all neurocognitive impairment was present prior to the transplant. So again, it stops any kind of decline. You don't get anything back, but it halts any kind of worsening of the neurocognitive deficits. Just an attempt to humanize these diseases a little bit. And this is a very good article that was written about a young lady named Zoe, and it's worth a read. Zoe was a young lady who in retrospect very clearly had OTC deficiency, but nobody knew it. And so eventually she did, in college, end up passing away from hyperammonemia, and her parents, donated her organs, and her transplant recipient then in turn died from hyperammonemia, and then they figured it out. And so, this is worth a read, Zoe's story, and her parents are now very involved in the urea cycle disorder space and big advocates. Moving along, tyrosinemia type 1. So this is autosomal recessive. This is also called hepatorenal tyrosinemia. And, I kind of cheekily here put that under presentation, not applicable. We are very good at screening for tyrosinemia type 1 these days. Considering some families opt out of the newborn screen, and some babies who are born in Mexico may not be screened for this and may make their way here, it is worth actually talking about the presentation. The presentation realistically is just liver failure, and usually it's going to present sometime before 6 months of life. Usually the synthetic function of the liver is particularly affected, so you get, edema and bleeding and all sorts of stuff. And then you also have some degree of renal involvement for these patients, whether that be just mild tubular dysfunction all the way up to renal failure for these patients. In terms of diagnosis, so again, going back to our plasma amino acids, you'll see high tyrosine. There's a couple of different things that will give you that. By far the most common is something called transient tyrosinemia of the newborn. Any providers who work in the NICU are going to be familiar with this. Essentially, babies are born, their livers are relatively immature, and they're just not great at processing tyrosine. But for those patients, it's actually not that big of a deal. In fact, it's no big deal. What separates tyrosinemia 1 in terms of screening apart from the others is your succinyl acetone, right? So if you get your newborn screen back, you see high tyrosine, but my succinyl acetone was normal, I'm not worried. Versus if your succinyl acetone is high, that's, there's not much that will do that. That's pretty, diagnostic for this. And succinyl acetone and its derivatives are actually what drives pathology in this disease. So you get free radical damage due to the depletion of glutathione, very carcinogenic due to inhibition of base excision repair. We're doing fine on time. I'll tell you one of my favorite fun facts about tyrosinemia. Back in the day when you were doing autopsies on these patients and you were sectioning through their liver, what you would see is just cirrhosis, maybe some hepatocellular carcinoma, but then in most patients, you would actually see little pockets of what looked like healthy liver tissue. And what they found was happening when you would look at the pockets of healthy liver tissue is that the patients were having so many, mutation events that they would inevitably reverse their tyrosinemia. And so those little pockets of hepatocytes that didn't have tyrosinemia, they were able to grow a little bit and do well. So very carcinogenic, even to the point where it might cure itself. Again, it's other problems, but those patients didn't necessarily survive. And then some of the products of succinyl acetone are directly neurotoxic. So in terms of treatment, in the past, we didn't really have much, right? We would restrict the tyrosine that they eat, and they would get a liver transplant. Now we have a medicine called nitisinone, which is very good. And it essentially takes a patient who otherwise has tyrosinemia type 1, and it turns it into tyrosinemia type 3, which is a much, much better disease to have if you had to pick one. About 90% of patients really should respond to this. And so only the patients who don't respond are the ones who are getting transplanted these days. So, a minority of patients with tyrosinemia type 1 are getting transplanted these days. The other thing that's notable is in terms of patients who were screened positive and were started on nitisinone, none of them have developed hepatocellular carcinoma so far. So this medicine works really, really well. You still do put them on a low phenylalanine and low tyrosine diet chronically. So here's sort of a schematic of what that is. If you have tyrosine and you just metabolize it normally, things are all good, right? But if you have tyrosinemia type 1, you're going to start making succinyl acetone. You're going to make all of these side products that are carcinogenic and just bad in general. So we give you nitisinone. It blocks the pathway up here, and it kind of gives you tyrosinemia type 3, which is not as bad as tyrosinemia type 1. Moving on to the organic acidemias, or well, in this case, we'll just talk about methylmalonic acidemia and propionic acidemia. These are very similar diseases and right after each other in terms of metabolism. In terms of signs and symptoms, you'll have axial hypotonia with limb hypertonia. You'll have these large amplitude, non-epileptic myoclonic jerks, which again, if you let this go on for long enough without treating them, eventually they do develop seizures, right? But initially they're non-epileptic. They will have a high anion gap metabolic acidosis. In this case, the gap anions, the mystery anions, are the organic acids themselves, right? It's methylmalonic acid or it's propionic acid or their derivatives. You'll have hyperammonemia, you'll have pancytopenia. You can have metabolic strokes in the deep brain structure. So the basal ganglia are particularly susceptible to strokes in the organic acidemias. In terms of your diagnosis, actually all three of the metabolic labs are useful here: your plasma amino acids, your acylcarnitine profile, and your urine organic acids. So for your PAA, you'll see elevated glycine. Still unclear why, although I will point out, for the neurologists or maybe some of the hospitalists and neonatologists, if you've ever taken care of someone with glycine encephalopathy, another name for that is non-ketotic hyperglycemia. You probably never wondered, but that distinction, non-ketotic, is because of these disorders. In the past, these were the ketotic hyperglycemias. On your acylcarnitine profile, you'll see elevated C3, propionyl carnitine. This is what we use on the newborn screen to actually screen these patients, is propionyl carnitine. And on your organic acids, you'll see methylmalonic acid, you'll see 3-hydroxypropionic acid, you'll see methyl citric acid. So that's how you diagnose this. In terms of treatment for these patients, again, first principles, right? We want to remove and or stop the buildup of substrates proximal to the defect. In this case, the offending agents are methylmalonic acid and propionic acid. These are derived from valine, odd chain fatty acids, methionine, isoleucine, and threonine. So the mnemonic for that is vomit, by the way. And so you'll give these patients a normal saline bolus for two reasons. One, they're usually quite dehydrated, but two, MMA has a high renal clearance. So oftentimes you can give them a bolus, and then their kidneys will do most of the hard work for you. You'll make them NPO. You'll give them dextrose fluids, as we talked about before. You have to give them carnitine. They do get a secondary carnitine deficiency just because their body there's so many propionyl derivatives that are being sort of attached to carnitine and then peed out that they get a carnitine deficiency. And it's propionyl-CoA and its derivatives that actually lead to all these other problems by inhibition of various enzymes. And so that's why these patients will get hypoglycemia, hyperlactatemia, hyperammonemia. That's due to inhibition of NAG-S. If you remember from before we were talking about NAG-S, there's a medicine called Carbaglu that we use for patients with primary NAG-S deficiency. You can use that for MMA and PA, and it works really well in getting rid of getting the ammonia down acutely. Some patients take it chronically, and maybe there's some evidence to suggest that keeps them out of the ER more than not. It's not really super convincing, but I do have a few patients on that. In terms of transplants for these patients, this one's probably a little bit more controversial than for like urea cycle disorders, but we still often do it. The problem is it doesn't fully eliminate the risk for decompensation. There have been some patients, rare, but there have been some patients who had metabolic decompensation or stroke after transplant, but it is quite rare, and it really does reduce the risk significantly of having that problem. We don't know the long-term outcomes yet for patients with organic acidemias getting transplant. The other consideration for MMA specifically, the natural history of this, if you were to just do medical management and treat these patients, probably late teenage years, early adult years, they're going to have kidney failure, almost regardless of what you do. And so traditionally you would do a kidney transplant, you would do a combo, kidney and liver at that time. Now the question is, should we do a liver transplant early? One, to improve their neurocognitive outcomes, but two, there may be some evidence to suggest that doing the liver early maybe not prevents, but can, lead to better kidney outcomes. More to come on that in the future. And so who are we transplanting? Is it everybody? No, usually it's only the most severe patients, or the patients who are, just not doing well on the medical management. But many patients do get transplanted with organic acidemias. I think we're doing okay on time. So another sort of human story in terms of the organic acidemias, just Stallings. In 1991, she was sentenced to life in prison for the murder of her son Ryan due to antifreeze poisoning. Ryan showed up with a high NI-gap metabolic acidosis. The Children's Hospital tested his blood. They said, "Hey, we see a lot of ethylene glycol there," and so Ms. Stallings was convicted and sentenced to life in prison. Now, she was actually already pregnant with her second child, David, and gave birth while awaiting the trial. Depending on how you look at it, fortunately for Ms. Stallings, or unfortunately for David, he was diagnosed with MMA. And although this didn't really play a role in her actual trial, later on it did, because Dr. William Sly, who was a biochemist, he has the name Sly syndrome, or mucopolysaccharidosis type 7, is named after him. He actually saw her case on episode Unsolved Mysteries, and then he was critical in chasing things down and proving that no, Ryan actually did have MMA and died from that. And so she was acquitted, or she was released from prison, and then she sued everybody involved in Ryan's case and settled out of court, and hopefully got quite a lot of money for all of that. And so last but not least, let's talk about glycogen storage disease type 1A. This is a problem of hypoglycemia. And just to point out here, if we think about where our blood sugar comes from in terms of fasting, this is where it comes from. So you eat at time 0. For the next 3 to 4 hours, your blood sugar is going to be primarily reflective of that meal, right? Now, obviously, we don't have to eat every 3 to 4 hours. Babies do, right? Because they don't have good glycogenolysis or gluconeogenesis. But so babies eat every 3 to 4 hours, right? But you or I, we have stores of glycogen, right? And so that's stored in the liver, that's stored in the muscles. So depending on how big your liver is, how big your muscles are, you can fast for the next 12 to 16 hours just on glycogen, just on stored sugar. And after that, gluconeogenesis is going to primarily take over. Patients with GSD type 1A actually have impaired glycogenolysis and gluconeogenesis. And that's because you have all these potential things that the body can use for energy, but it's really, really good at using glucose and turning that into energy. And so what the body has decided is that let me just take everything, turn it into glucose, and then use that glucose to make energy. And so for these patients, that last step, right, that conversion of glucose 6-phosphate, removing that phosphate and just having glucose, that doesn't work for them. And so they have profound, very precipitous, very quick hypoglycemia. They're short due to inhibition of insulin-like growth factor. They have gout for biochemical reasons. They can get hepatic adenomas, and those can transform to hepatocellular carcinomas. And they just have a ton of problems. So how do we treat this? These patients literally eat every 3 or 4 hours. It gives them cornstarch because it's kind of broken down at the exact rate that you would want it to be broken down in order to maintain a normal blood sugar in between meals. And so usually what this looks like is patient will eat breakfast and cornstarch. 4 hours later, they'll eat cornstarch. 4 hours later, they'll eat lunch and cornstarch. 4 hours later, they'll eat cornstarch. And so that's their life. Initially, there was a big search to find what is the best starch that would work for these patients. And fortunately, just the cheapest one is the one that works the best, just plain old Argo cornstarch. The other one that works quite well is, if you want to be bougie, is tapioca starch from cassava plants. So the patients do have to avoid certain sugars because, again, the body wants to just take these sugars, turn them into glucose, use that for energy, but they can't. And so, eating this is just going to contribute to higher lactate levels in these patients. They get gout, so we'll use allopurinol. They have very high triglycerides and cholesterol, and they have renal disease, so we'll use statins, fibrates, and ACE inhibitors. What about transplant for these patients? Transplant is curative. These patients don't have low blood sugars, and essentially all of their biochemical problems would go away. But we don't routinely transplant these patients. We really only transplant them if the dietary therapy is not working so good. So if they develop adenomas, usually it's going to be in the teenage years is when they're at highest risk for this. And those adenomas don't go away with more aggressive dietary, just being more strict with your diet and avoiding hypoglycemia. Or if you have those adenomas transformed to hepatocellular carcinoma and they don't have metastasis, you would transplant them, of course. And then there is the caveat that just says, if your patient has poor metabolic control, you consider a transplant for them. So usually most patients we're just managing medically. And this study was looking at survival for patients who underwent transplant for GSD versus sort of age-matched controls who underwent transplant for other patients. On the top here is actually the GSD patients. So they did slightly better than their peers. And so at the 1 year post-transplant survival was 82. At 5 years, it was 76. And 10 years, it was 64. So in conclusion, despite improvements in medical management for many of these diseases, outcomes are not so ideal in some cases. And so liver transplant represents a pretty attractive option for many diseases. In some, it's totally curative. In some, even though they're partially responsive, substantial benefits can be seen, right? Whether that be just not being as strict with your diet, which is a huge plus for the family and for the kids, and significantly reducing the risk for catastrophic complications with metabolic decompensations. And then, over the years, we've gotten better at doing liver transplants. And so that risk to benefit ratio for children with more mild disease, it's shifting in favor of liver transplant, even for some of those patients. And then last but not least, hopefully one day gene therapy, puts us all out of a job, or at least me, kids will still have structural liver disease and need transplants and such, but maybe one day. So happy to take questions. This is the number for the genetics clinic at Christus. This is my email. You can send me emails. If you have patients, send them over. Flag them as metabolic. I would be the metabolic ones, and we can see them faster. And this is the team. We have our newborn screening nurse, Alma. Many of the neonatologists have probably talked to her. This is Jen, our metabolic dietitian. This is Alex, our nurse practitioner, who is now up in Austin, but she is still an honorary member of the team. And this is Sam, who's my infusion nurse, who handles the lysosomal patients and other weird and expensive medicines. So yeah, thank you.
Thank you. Thank you, Dr. Odom. That was wonderful presentation. Lot of information. I hope we were recording it because I'm getting text that some people need the recording to slowly digest all the information you gave to us today. Let's see the questions. I think there was one question. Let me see. Can you read that?
Yes, yeah. So I
Yes,
see a
okay.
question that says, are there cases of PKU that would be considered for transplant? And the answer is no. I don't know that it would really achieve what we want necessarily, which is normal neurotransmitter levels in the brain. And we just have better medicines for PKU patients. The other thing I'll say about PKU is, as long as you can control things in the sort of formative years, babies to infants, which is pretty easy because like they're drinking formula mostly for anyway, and obviously we control what they eat. Then IQ should be quite normal. Let's say you have a patient who's controlled as a baby who grows up and now they're a teenager and they want to rebel and they're eating meat and cheese and all sorts of stuff, and their Phe levels are high. What that looks like is brain fog, symptoms like ADHD, that sort of stuff. But notably, you can, once they, get back on their diet, things go back to normal. And so the risk for intellectual disability and autism and all this stuff is really only for patients who are untreated as babies. So, if you had someone older who was not well controlled, again, we have a lot of different ways to approach that problem, but in that situation, liver transplant is probably not all that useful for them.
Thank you.
And then
I think there is one more question.
And then I see Dr. Lynch has their hand up as well. So this is a question about Wolman disease and what are their options as they move into adulthood? Do they continue followed by pediatric specialists? So I actually don't have any patients with that right now. For the record, I see adult patients. I don't know that there's any adult-specific metabolic doctors out there. And so, I just make it very clear. I tell my patients, I will continue to see you as long as you want. I have patients who are 70, but I don't know a whole lot about adult medicine. So I'll handle this stuff, but like you got to, if you have a question about adult stuff, you got to ask someone who knows.
Actually, we diagnosed two cases, one pediatric, one adult. This is very rare. And the pediatric patient did very well on the infusion therapy and now transferred to the adult counterparts. Any more questions?
This is Dr. Lynch. Can you hear me?
Yes.
I have a question. How are we using the data from the Texas newborn screen for either research or just data for the state of Texas to extrapolate?
Mm-hmm. So periodically, the state screening lab, they're up in Austin. They will put out some internal data and some numbers on that. If you want to use their data, which I've briefly looked into at one point or another, it's just tough because it's the government and you have to go through your own IRB, you have to go through their IRB, and you're probably looking at many months of back and forth paperwork and that. So I don't know anybody who is currently using their data external, but they publish like false positive rates for the newborn screen and that sort of stuff periodically.
That was our experience too, and it's got to be a wealth of data. Just a commentary.
Yeah, no, it definitely is.
This is Dr. Gong. I'm on the Newborn Screening Advisory Committee and have been for a long time. The reason that data is the way it is has to do with all the lawsuits that were raised against the newborn screening program for having the data and also sharing the data at one time. And that's the problem, why there are so many safeguards that were put up, and it had to be, otherwise legislation was going to make it even worse.
Yeah, and you might say, oh, this is just Texans being overprotective and worried about the government. but there was a pretty high profile case a couple of years ago in New Jersey where the police could not get a warrant for their suspect to obtain a DNA sample. So they subpoenaed the newborn screening program, got his kid's DNA. They said, this is a 50% match for our suspect. And then the judge granted them a subpoena or warrant, and they were able to, make their case. So, it's not just, it's not just people being paranoid about, overreach necessarily. There are some rare, very rare cases where you say, oh, maybe they shouldn't have undermined the, public trust in the newborn screening process just to catch that one criminal. But
I think Dr. Garcia has a question.
oh, yes. So they say, how long after liver transplant do the kiddos need to be kept on their pre-transplant special diet? And it depends. If you are, let's say you have a urea cycle disorder, where we say that is quote unquote curative, as soon as the surgeons in the operating room hook up blood flow to their liver, I'm done, right? They can eat what they want. They don't need to take their medicines. They still need to supplement citrulline depending on the disease. But for that one, it is truly, truly curative. For things like MSUD, we saw that some of the post-transplant patients still maintain a little bit higher, not like, oh my goodness, high, but like a little bit higher leucine levels. If I had a patient with MSUD who was transplanted and their leucine levels were still running slightly high, totally off diet, we would say, let's bring it back a little bit. And then for MMA and PA, because some patients do still have metabolic strokes afterwards, very rare, but it's not a 0% chance. Those patients we will still maintain on diet just to be extra safe. So it's really disease specific.
Thank you. Any more questions? While waiting, the Zoe story you mentioned, did she have OTC?
Yes. Yeah, she had
career?
OTC deficiency.
My understanding is X-linked males will present and females may have disease if they have suppression of the normal gene, and that's
Mhm.
an hypothesis. But I took care of one girl who needed transplant, but females often have cirrhotic liver. So how was that missed when her liver was transferred to another recipient?
I guess she just didn't have necessarily that manifestation. Dr. Lindsay Burge at Texas Children's Hospital is doing a lot of research on structural liver disease and cirrhosis and the long-term complications that you get. Now that we're better at taking care of urea cycle disorders for patients with more mild diseases who you wouldn't necessarily transplant, or where the family just doesn't want to do it because the kid's doing so well. You say, well, what does that look like when you're 30 years old and you have OTC deficiency? We don't know. And so, but many of the disorders we are seeing, more cirrhosis. So she's looking at like liver elastography and that sort of stuff. So we should know more about that eventually.
Right. That's my understanding that females with OTC will develop chronic liver disease with fibrosis and cirrhosis. Second question I have, you mentioned ASL deficiency, not a good candidate for OLT. Can you shed some more light on that?
So for those patients, ASL, arginine succinate lyase deficiency, is a urea cycle disorder. They have neurocognitive deficits regardless of whether or not they have metabolic decompensations or they have hyperammonemia. To be clear, if they have hyperammonemia and they're ended up in the hospital with cerebral edema, yes, that is bad for their brain. But even if they don't have that, they still have neurocognitive deficits regardless of that. And that has to do with so ASL is expressed not just in the liver, but everywhere, including in the brain. And in the brain, instead of doing what it normally does, you have a buildup of these guanidino compounds. Again, I think that was Dr. Lindsay Burge who really reported on this. And that is probably driving the neurotoxicity in these patients. And that is, again, why we no longer give them such high doses of arginine, and we do low dose arginine for ASL patients in an attempt to minimize the neurocognitive problems from that.
Yeah. Wonderful. All right. I think it's time to close. It's 8:29. Any more questions before we thanks Dr. Odom for this wonderful presentation and look forward for more to learn from him in future.
All right. Well, thank you so much for the opportunity. This was
Thank you.
fun.